All right, so we're going to take a look at some foot and ankle injuries, and we're going to look at it in the context first of understanding what the anatomy is that's involved, what are some predisposing factors to it, what are the common signs and symptoms that people are seeing, and then we're going to also look at how we might be able to help people with a corrective exercise continuum to help to get them back and moving freely again. All right, so let's take a little bit of a look at our anatomy, and we're going to first start with the bones of the foot. So I do have a friend that once came up with a mnemonic to try and remember the different bones of the foot, is looking at it like a boat. So here, we've got the calcaneus, and that is the cabin of the boat. We have the talus, he's the tallest of the bones, and that is our captain of the boat. Right next to the captain, remember, we always have our navigator, which is going to be our navicular bone that we have right here. Then we have the cabin boy that's off on the side, and we've got the three cuneiforms all in their cuneiforms swabbing the deck. So that's just a little fun memory aid that I have used in the past that a friend taught me about tarsal bones. And then we also have our metatarsals. Remember, this is still underneath and considered a portion of the foot, versus our phalanxes or phalanges are the portions that are actually our toes that can wiggle. So those are our bone setup as far as the foot goes. Here we've got the ligaments, and when we take a look at the ligaments, they are made up of three. The ones on the lateral side, the outside of our ankle, is the anterior talofibular, the posterior talofibular, and the calcaneofibular. So I just love how these are always named. That goes exactly, it tells us exactly where the ligaments are going to and from. So here's our calcaneus bone coming up to the fibula. So this is our calcaneofibular ligament. And then here we've got the talus bone or the talus bone. And we have one that is going from the talus to the fibula, and it's on the anterior side of it. So that's our anterior talofibular ligament. And then we also have one that's coming off the back. So this is our posterior talofibular ligament that we have. These are treated as three separate entities and three different ligaments. When we look at the medial side of the foot, on the medial side, it does have these three different sections of it, but it's all considered one ligament as the deltoid ligament, and that's on that inside version, on the inside of our ankle. Now, the thing that we want to take a look at is the strength of these. You can see that here we've got them closely packed together, and they're larger ligaments in general. And so it almost makes up a triangle shape, hence the deltoid for our Greek letters of delta. And here on that lateral side, there's smaller ligaments and they're more spread out. So as far as stability goes, we have a lot more stability when we are looking at the inside of the ankle on that medial side with the deltoid ligament compared to on the outside lateral side with our three other ligaments. What this means for us is that traditionally, when the ankle rolls, it tends to roll towards the inside because it's a stronger ligament and also the way that the anatomy is fashioned together. Which means is that we typically will roll the lateral side and injure the lateral side of the ankle when we are experiencing a sprained ankle. Next, we're going to take a look at a little bit of a review of our muscles. So when we take a look at our muscles, we do have flexors and extensors, and then we also have our lateral compartment as well. So on the medial side, and mostly on the posterior side, we have all of our flexors. So really deep down, you would see the tibialis posterior, and then right in front of it, So that's our posterior, our tibialis posterior right there. Then we have right here our flexor digitorum longus coming all the way down to all of the digits. And then we also have our flexor hallucis longus that comes all the way down just to our first toe, because hallucis is our big toe. So it goes in the order as far as starting at our medial malleolus that we have right here, and working our way more posterior. A way for us to be able to remember that is Tom, Dick, and Harry. So Tom is for the tibialis posterior, Dick is for the flexor digitorum longus, and Harry is for the flexor hallucis longus. So that's ways to be able to remember our anatomy. On the front side, we have more of our extensors, and you can kind of see them from this profile picture, but we have our extensor hallucis longus that will come down all the way to the big toe. We also have the digitorum, the extensor digitorum longus, that'll come all the way out to all of our toes here. And then we also have a brevis that's just right here on the foot for both the extensor digitorum brevis, and there's also a extension hallucis brevis as well. Hugging really tight, and you can't really see, but on the front of the tibia, we will actually see the tibialis anterior. Here on this lateral side, what we can see is our fibularis muscles, or perhaps we can call them peroneal muscles, whichever one works best for you. Those can be used interchangeably. So we have the fibularis or peroneus right here, longus, and you can see it's got the longer tendon as it's coming down here, and it's going to cross over and go all the way over towards the medial side of the foot. Then we have underneath it the fibularis brevis that comes down and attaches right here on that tuberosity of the fifth metatarsal. And then we actually also have a third fibularis muscle called the fibularis tertius, as in for the third, or peroneus tertius. And you can see it coming right down here. It almost looks as if it's a part of the extensor digitorum longus, but then it breaks out and it comes to this tubercle, and it doesn't actually go all the way down to the phalanges. And so that is our peroneus tertius that we have right there. The last thing that I want to talk about as far as the anatomy is we're going to go as superficial as we really can go, and we can see the plantar aponeurosis. So you can see that located and tagged here. This is also what we know as our plantar fascia. So when we talk about having like plantar fasciitis and talk about our plantar fascia, that's really the plantar aponeurosis, and it's just a common integration point of the foot. We can also find ones that are similar to this, like in our hands, but in the foot, it's a tougher and larger area and structure, and so it can actually cause a lot of problems as we start to tighten our foot more and more. Okay, so we're going to take a look at our foot and ankle injuries, and when we look at our joint by joint approach, as far as whether it is more stable or if it's more mobile, we really want our ankle to be more mobile, with the foot actually being stable. So we want a stable foot with a mobile ankle, and a lot of us have really tight ankles, and it causes a lot of issues for us over the long haul, and that's why we have chronic instability of the ankle, is that it's actually because it's not mobile enough. And what can happen when we don't have enough mobility in the ankle is it can actually lead to some issues in the hip. So it works its way up the chain and can cause weakness in the hip and overcompensation on the other side. So let's take a look at some of the common injuries, and we're actually going to start off with our plantar fasciitis. So what is plantar fasciitis? Well, we have itis, which means that it's an inflammation. So it's inflammation, and it's often accompanied with like a partial tear of the plantar aponeurosis, which is that thick band of tissue that you can see on the bottom of the foot that we just looked at. And when we look, so that's our anatomy that's involved, is the plantar aponeurosis or the plantar fascia, whichever you would like to call it. As far as movements that are sometimes affected, dorsiflexion can be affected on it, but really it tends to be more of a predisposing factor, and we'll talk about that in just a moment, as compared to a movement that's affected. So as far as the location of the pain, we have pain in the heel of the foot. It tends to congregate right around that calcaneus. So it's usually towards the back of, or the more posterior side of the foot itself. It is on the plantar surface, so that's that foot surface that hits the ground. And it tends to hurt more in the morning when you're first getting up, and then after standing or sitting for a while and getting up to walk around. Particularly also when climbing stairs and going up, it tends to hurt, or with intense activity. So those are the time periods that it tends to hurt more. As far as what might make somebody more predisposed to having or contracting plantar fasciitis, having a decrease in their dorsiflexion. So if their foot is constantly kind of plantar flexed, think of things like in high-heeled shoes, right? We're often more plantar flexed in those because just the design of the shoe itself, and a lot of shoes, and it doesn't have to have that high of a heel to do that. It's just when you're constantly in that type of a position. If you have a foot type that's considered more pronated, you are more predisposed to contracting plantar fasciitis or experiencing it. If you're a larger individual, especially in a non-athlete's stature, we tend to experience plantar fasciitis a little bit more. If you've been doing a lot of long distance running, specifically if you're running downhill a lot, or if it's on uneven terrain, just the foot compensations that have to happen, and you're also often in that plantar flexion while you're running, especially when you're running downhill or on those uneven surfaces, that it can cause pain of plantar fasciitis. If you've had a sudden weight gain, so you all of a sudden had an extreme change in your weight and gained a lot of weight up all the way until obesity, we could be exposed more to our plantar fasciitis or predisposed more. And then if you're using shoes that don't have a good arch support or have a really soft soles, that can often lead to plantar fasciitis as well. So those are some of our predisposing factors that we have. So as far as recommendations of what we're going to want to do if we're experiencing plantar fasciitis. Now, we do have things like nonsteroidal anti-inflammatory drugs, such as like ibuprofen, and there's always the question of whether we should be using that or ice. And as you know, if you've taken the inflammation information in, that really when we're looking at it, that ibuprofen or nonsteroidal anti-inflammatory drugs actually can start to decrease the healing time. So we really need to take a look at, are we just trying to treat the pain, or are we trying to actually decrease the inflammation, because the inflammation itself is causing the problems. So yes, there is inflammation with plantar fasciitis, but you want to make sure that it's a normal, healthy inflammation, in that it's showing that we're going through the healing process. However, if you had a severe amount of swelling, then we might want to consider dealing with the inflammation and swelling on its own by taking ibuprofen. The same goes with ice. Ice, we're actually looking at that it can actually slow the healing process, and perhaps maybe it's not as good to be icing it compared to if we choose not to. As far as rest goes, yes, this is an activity that we would, or this is a condition that we would want to rest when we are experiencing, because anytime that you're walking around, you are going to inflame that more and just cause more issues to it. Really what we'd like to do is unload that plantar aponeurosis or the plantar fascia. So we want to make sure that we have really good supported arches. We can do that by just making sure we have good quality shoes that do have a good arch. There's also orthotics that can be used to help get the arch into a proper position, or taping techniques that can be used. Or we just want to make sure that the shoes that we are in have a little bit more of a drop in them, meaning that the heels are not lifted up, but instead are more down compared to the toes, or at least level. When we're at night, one of the best times for this is one of the best times for us to actually start trying to proactively treat the plantar fasciitis, because it can happen within our sleep with stretching. So having it immobilized at night and having it stretched into a really good dorsiflexion of having those toes pointed up. If you have like a walking boot from a previous injury, that would be a great time to wear it, because it's going to put you into that good position of dorsiflexion, and it also decreases the pain then when you get up in the morning to walk around, in which you can actually take off the boot to walk around and just instead immobilize it during the nighttime. As far as the corrective exercise continuum, so remember, we're going to first start by an inhibition and lengthening those overactive muscles, and then we'll turn around and we will activate and integrate the muscles that need strengthening. So for inhibition and lengthening, ones that we want to particularly pay attention to would be the gastrocnemius and the soleus, so our calf muscles. And then we also have a plantar fascia stretch I'm going to show you on the next slide that actually can really help to lengthen that plantar fascia. It takes a long time. It's not like an easy stretch to do. So we really want to be holding it in positions for an extended period of time, like trying to do it for about 3 minutes or so. It would be also great by inhibiting if we could, besides just stretching the gastrocnemius and soleus, but also inhibit them with like a foam roller and doing some self-myofascial release. We also can work on the plantar fascia with rolling. You can either use like a lacrosse ball. Typically, a tennis ball is a little bit too, gives out just a little bit too much. It's a little too soft to use for a tennis ball, but a lacrosse ball works really well. Or even better, you can use a frozen bottle. So it does actually help with the pain. If you're wanting to use ice on it, that is a good way to be able to use it. So you're using ice if you feel like you really need it, but you're actually rolling it at the same time. You can also roll it just on a bottle that's not frozen and not use the ice as well. For activation, some good exercises for us to consider would be resisted dorsiflexion, resisted plantar flexion, resisted inversion and eversion, as well as doing a towel curl up or a towel pickup or marble pickups. And I'm going to show you videos of those in just a moment. But first, I just want to come back and talk about the prognosis of the plantar fasciitis. It's usually healed without any surgical means in about 9 months. It is a long injury to have, and it will cause pain for an extended period of time. So please just realize that, and realize the importance of heading it off before it sets on, so that you don't have to go through 9 months of excruciating pain. It can last even several years to up to 2 years. And when this is happening, if it's for an extended period of time, you do want to make sure you're getting to the doctor, because there are bone spurs that can actually develop within the plantar fasciitis or within the plantar fascia that would need to be removed. And that's when surgery is indicated, only when there are bone spurs present. And your doctor can help with the doctor can try and help with that determination by doing scans, by doing an x-ray to find out if there are bone spurs present on the calcaneus. So just taking a look at the inhibition and lengthening. So here we have an example. You could be a frozen or unfrozen bottle that you can just roll. You could also be using a lacrosse ball to do that, to dig in at those surfaces. When we do that, we are going to increase blood flow in the area, which will help to heal by bringing more blood flow to that area and to help deal appropriately with inflammation. Over on the right, you can see the picture of the plantar fascia stretch. So what we can do is put our toes up on a step or on the stairs and drop our heels down, and you get a really good elongation of that plantar fascia the more you do it. So in holding this for a good few minutes can work wonders over time, just making sure to do it for a long enough period of time and do it repeatedly throughout the day. Looking at some activation exercises, we're going to look at our resisted eversion, inversion, dorsiflexion, and plantar flexion. So for all of these, I used a TheraBand that was just anchored to a table leg. You can see that in one of the pictures. But here we go with our resisted eversion. So remember, we're putting that eversion coming out and rolling that ankle towards outside. So we're putting the bottom of the foot. And first I started off really slowly, and then I started to pick up the speed. So you can do variety of doing it really slowly or doing it fast. Here we've got our resisted inversion. So I was on the other foot for this one. So you're just trying to roll that ankle so that you have the bottom of your foot facing more towards the inside. And again, I started off slowly and then I started to do quickly as well. And you can alternate between those and just do it based off of what is giving you the best results and what is causing the least amount of pain, but trying to include variety. For our resisted dorsiflexion, we've just looped the foot over through that TheraBand again, and we're going to pull our toes towards us in that dorsiflexion way. So we're just pulling our toes towards us to get that resisted dorsiflexion. I can then turn it around and have my foot going the opposite direction, in which for the opposite direction, then what I'll do is I'll be pushing my foot down for resisted plantar flexion. So this is another great exercise as far as trying to get all four of the motions done. So I've got inversion, eversion, plantar flexion, dorsiflexion, and I get all of the ranges of motion for our ankle to build up that strength in. All right, so that was our plantar fasciitis. We have one more exercise that we can do, which is our towel curl-ups, or the tower. It's also a towel toe curl-up, or sometimes it's called a pickup. You could also do it with marbles if you wanted. But here what you'll see is that I'm scrunching the toes to try and gather that towel as much as I can underneath my foot. Right? And so I'm getting a lot of work in there. And eventually I could even start to pick it up with my toes as well. Or that's what we could do with the marbles. If you've got marbles on the ground, you're trying to grab marbles, just like we did with that. We used our toes to grab the towel and pick up those marbles. So that's what we have for activation exercises for our plantar fasciitis. So next we're going to take a look at our Achilles tendinopathy, another common condition that we can have. So it's inflammation or degradation of the Achilles tendon. So that is the tendon that is coming down as a joint tendon between the gastrocnemius and the soleus. That's our Achilles tendon that we have. So it's that tendon there of the gastrocnemius and soleus. Sometimes when we are as far as movements that are sometimes limited or can cause pain, dorsiflexion is often affected with our Achilles tendinopathy. You can imagine that if we've got that inflammation or partial tearing of that Achilles tendon, bringing our toes up into dorsiflexion could actually cause a lot of pain for our clients. So as far as that location of the pain, it is on the posterior side, right at the Achilles tendon. It tends to be down towards the calcaneus, and it's usually about like 2 to 6 centimeters proximal to the insertion onto the calcaneus. So about 2 to 6 centimeters up from that calcaneus. And it tends to hurt more during activity, either at the beginning or the end, but it tends to be okay when you're exercising in the middle of it. And then if you are a person who wears high-heeled shoes, when switching from high-heeled shoes to low shoes, that will experience pain as well, just simply because you're stretching it out more. And you can actually see in this picture the swelling, the difference that you can see between the Achilles tendon here on the right foot as normal and on the left foot when it's inflamed. So as far as predisposing factors go, a person who is running or jumping a lot, you're using a lot of calf muscle there, and so that will tighten up over time. If you have decreased activity in the tibialis anterior, rectus femoris, or gluteus medius when you are doing your heel strike for when you're walking. If for some reason you've got a decrease of range of motion in your knee, so if you've been dealing with knee injuries, the compensation that can happen is a lot more of our plantar flexion. It can start to cause issues as well. If you're training on slippery or slanting surfaces that are not stable, or if you have excessive coronal movement in the hind foot. So when you're walking, if you get that lateral heel strike as you're walking, that can often cause problems, as well as just the risk factor of obesity causing Achilles tendinopathy because of the weight that's associated. So just looking at the anatomy a little bit more, we've got our musculotendinous joint that's coming down, right, to come into the tendon itself. So here's our Achilles tendon that's coming down. And what you can see through this scan is actually looking at the innervation, or not the innervation, but the blood supply that we have here. And you'll notice there's an area that doesn't seem to have quite as much blood flow compared to the other sections of the tendon. This is precisely where the Achilles tendinopathy tends to occur, is in the places that have less blood flow, as we're less able to heal it if something is going wrong with it. So as far as recommendations go, painkillers, again, that's questionable as far as it will decrease it slows down the healing and will impair healing, same as ice. And so we do want to consider those things before using them. But if we have extreme swelling in that area and we need to deal with that inflammation itself, that's when we might consider it. We do want to rest from the activities, but only the ones that are provoking pain. So if you're able to do some activities without pain, I would say keep doing those activities. We do want to keep the ankle mobile and be able to keep that mobility in it. So if we rest it too much, it can actually become a little bit more stiff. So we do want to move it, but don't do anything that is causing pain to it. There is some techniques of using ultrasound to go in, and when you are using the ultrasound, it actually increases collagen synthesis in that tendon, and so it starts to build new tissues there to help heal the damage that has been done. So you can use ultrasound or sonography to actually go in right at that local area to try and build up that collagen again. As far as the corrective exercise continuum, so with our inhibition and lengthening, we do want to focus on that gastrocnemius and soleus again, as well as we could incorporate that plantar fascia stretch. So rolling and stretching the gastrocnemius, the soleus for our calves, and also the plantar fascia, doing that stretch in which we put our toes on the stair and then dropped our heels down. As far as activation and integration exercises, when it comes to Achilles tendinopathy, eccentric contractions actually work best. So we can do eccentric heel raises, and then in combination with some step ups, but I would use a small step up, just maybe like a half step or so. And then ultimately start strengthening the stabilizer that are up the chain. So remember, if we were having knee issues, it was prone for this. So let's start trying to stabilize the knee a little bit more and be able to kind of head the problem off that way. As far as the prognosis goes, about 25 to 45% may end up needing surgery simply to remove some of the adhesions that are building. And in some case, they actually will go in and remove the sheath of the tendon in order to heal the area better. So taking a look at some of these activation exercises, I talked about the eccentric heel raises. So what you can see is the heel raise comes up, But what I'm going to do now, instead of going fast, is very slowly drop all the way as slow as I can until that heel will touch the ground. At that point, then I'll come back up onto the toes and then slowly drop over time until, and as slow as we possibly can until the heels hit the floor, and just repeat that as our exercise for eccentric heel raises. We also have step ups. So I'm just looking here, I'm stepping up. It takes a lot of balance and stability to step up and to land only on that one foot. So you can see that this can actually build a lot of strength in the stabilizer muscles, and it can really help us when dealing with our Achilles tendinopathy. But again, stick with like about a half step or so, not going up the full foot that a lot of people do. All right, so next we have our medial tibial stress syndrome, which is often referred to as our shin splints. So it is an overuse injury in which we have irritation to the muscles, and we can actually have small little stress fractures within the tibia itself. So little tiny fractures that are occurring on the tibia. So what is the anatomy that's involved? Well, the bone of the tibia is involved, including the periosteum that surrounds it. So that's the sheath that goes around our bones. There's a lot of innervation that happens with nerves innervating that, and also blood supply coming into it. So when it's disrupted and causes inflammation, we can experience that pain because of that. Other muscles that might be involved would be the tibialis anterior and or the tibialis posterior, and sometimes we can feel it also coming from the gastrocnemius. These are all different areas. We often think of shin splints as just being on the anterior side, but we actually can experience them from all different sides: anterior, posterior, medial, and lateral. As far as effective movements, depending on where it is, you'll have either plantar flexion or dorsiflexion as being affected and causing pain when contributing to those motions. So the location of the pain, it's usually about in the center of the tibia or so. It can be slightly towards the knee, slightly towards the ankle, but it's somewhere usually around mid-shaft. As far as the location of the pain, it typically presents itself on the medial side of the tibia, and it's usually in that distal third. So it's kind of in the lower portion of the leg, and it tends to inflame more during activity. This is kind of showing you a picture over here that down the front of the leg, it's most likely the tibialis anterior as far as the muscle that is being affected. And you're feeling it more down the inside portion of the leg. That's often the tibialis posterior that's affected. As far as predisposing factors, if you are a person who is overpronated, considered a flat-footed individual, that tends to make you more at risk for having shin splints. If you have passive inversion or eversion and or internal or external hip rotation and lack the muscles for stability at the hip, then we could be experiencing shin splints as well. So just ones that are naturally rotating out, either from the ankle itself or from the hip. Whenever we have a history of going from no exercise to a lot of impact exercise, such as taking up running or beginning basketball sports or track, then we're going to be able to experience, it puts us at higher risk of experiencing it. Or if we all of a sudden increased in the duration or intensity. So maybe I'd been normally running a couple miles a day, and all of a sudden I upped my distance to being, like 8 miles, we could see it come on. So whenever you're getting an increase in that duration or intensity, or if you move from running on a softer surface to a harder surface. So if you've been traditionally running on a track or say trail running and then go to the concrete streets or cement, then you could experience shin splints as well. As far as recommendations go, again, we're always going to question whether we should be using ibuprofen or an ice. As far as rest goes, impact activities that are provoking the pain, we should be resting from those. We can also put in some orthotics just to soften the stepping, like basically a shock absorber when we're walking. As far as the corrective exercise continuum with inhibition and lengthening, we'd like to do some self-myofascial release and rolling of the gastrocnemius, and also our tibialis anterior is a good one to target as well. You can also do an anterior compartment stretch. So looking at right in that location of the front of our shin where the tibialis anterior is, if we were to pull our foot up towards the back, towards our posterior, just as if we were doing like a quad stretch, standing up and trying to put our knees right next to each other. But instead of trying to focus on the front of the leg, focus on the shin portion. So really pulling that ankle down to get it really elongated into plantar flexion can help as well. As far as activation and integration exercises, for activation, we're going to do those resisted dorsi-plantar flexion exercises and the inversion and eversion ones that we were taking a look at earlier in the presentation. And we can also do heel raises and toe raises. And if we need to start without having to put too much weight on our body, we can actually start by sitting, and I'll show you a video of that in just a moment. As far as prognosis goes, really we can return to activity as soon as the pain starts to subside. So as soon as we're starting to feel better, we can go back up to our normal activity again. So looking at the activation exercises, here we're first sitting down, doing toe raises and heel raises. These ones are alternating back and forth, but you could also just do heel raises for a set of 10 and then just toe raises for a set of 10. But here we're actually alternating between toe raises and heel raises there. The nice thing is when you're sitting, it takes that weight of the body off of it so that you're getting good stretches and some mobility, but it's not putting too much pressure on the muscles themselves. Once that is feeling comfortable, you can progress to be able to go up to standing heel raises and toe raises. Just make sure that when you are going back into the toe raise position, it's not just a rocking back, but it's actually a concerted dorsiflexion movement that's happening. Sometimes it's nice to actually have something in front of the client. Right now we've got a bar in front of the client so that we can lift the toes up but not lose the balance. So taking a look at our last condition, it's going to be our ankle sprain and chronic instability. So what is it? It is damage to the ligaments. Remember we talked about the lateral side, the anterior talofibular, posterior talofibular, and calcaneofibular ligaments, or to the medial side, the deltoid ligament. But remember, it really is more common in that lateral side. So those are our ligaments that are involved with our ankle sprains or like acutely and or with having chronic instability of the ankle. Affected motions could be dorsiflexion, plantar flexion, inversion, eversion, and sometimes it's just more heavily weighted towards one versus the other. So maybe you have an easier time plantar flexing, less range of motion when you are dorsiflexioning, and then also for inversion and eversion, that goes the same way. So as far as the location of the pain, it is wherever that sprain was. So whatever ligament was damaged, that's where you're going to have some pain. If it's a chronic instability, you're going to have a feeling of like the ankle giving away constantly. And so that's another indication. Predisposing factors. If you've had a previous sprains, ligaments do not heal as well as muscles do. So if you've had a previous sprain, it's more likely that you would experience a sprain again. If you are constantly in dorsiflexion and not getting good dorsiflexion range of motion because of the shoes you're wearing or the way that you walk or the way that you even just rest and sit your foot, that can be a predisposing factor. If you have extremely high arches, that actually makes you more prone to ankle sprains as well. And women who have a little eversion of their calcaneus can actually be more predisposed to ankle sprains as well. So as far as recommendations go, again, we're always taking a look and evaluating how much swelling is going on. If there's a considerable amount of swelling, we might consider the ibuprofen. However, we do need to realize that it is going to lengthen the healing time as it stops that inflammation process, which is stopping the natural healing that's occurring. As far as rest goes, we do want to make sure that we are not aggravating it more, but we do want to get it moving as soon as it can. So finding that fine balance of not causing more pain and not re-injuring, so maybe resting it for like a day or two, depending on how severe the sprain is, and then working our way towards more mobility, and including mobility exercises to get it moving, and then weight bearing once we can do good ranges of motion. We can also consider compression and elevation if we are dealing with a severe amount of swelling. It can also help just to protect it a little bit when you are putting an elastic bandage on, as far as movements, to make sure the movements are purposeful movements instead of movements that occur just because of the injury itself. The corrective exercise continuum that we have differs on whether you're dealing with an acute injury or a chronic injury. So with an acute injury, things that we would like to do is like the towel toe curl-ups or that towel pickup that we had, perhaps the marble pickups. What it's doing is it's activating all of those stability muscles in order to do that. And so it starts to gain stability around that ankle to help protect it. We also want to keep the mobility going, though, of the ankle, and it doesn't become too stiff. So we will actually do some non-weight bearing range of motion. I'm going to show you in a moment one way that we can do that. Chronic injury, things that we could work on over time, so ones that you're just giving that ankle that is always constantly giving away. We can do a single leg balance, and you'll see in a video in just a moment how that actually does give a lot of mobility to the ankle itself that you are standing on. There's also exercises like doing windshield wipers with a towel on the ground. You can also do the resisted dorsiflexion, plantar flexion, inversion, and eversion that we've already talked about. With our prognosis, a mild sprain usually only lasts a couple days. If it's a more severe sprain, it could take weeks to maybe even months to deal with. Surgery may be indicated if it's a complete tear of a ligament or extremely severe. Otherwise, usually surgery is not needed and it's just going through rehabilitation. So as far as some exercises go, to increase our range of motion, we can do like writing of the alphabet or writing of letters with our ankle. So here we're tracing letters A, B, and working our way through the alphabet. You could have them spelling out their name. You could do it in cursive versus capital letters. This one happens to be in capital letters that we're doing it, but it really gives that good range of motion to build up that flexibility within the ankle itself. Here we've got the towel wiper blades. So you can see it's like going just like windshield wipers would be going on your dash or your window, or you could actually go in alternating paths. So they're going in and then out from each other. But you can see there's a lot of movement within the ankle itself while doing it. And we also have the single leg balance. So watch that standing ankle. That standing ankle there has a lot of reactivity that it has to adapt for when we are moving our moving leg in different directions. So as we challenge it, so it's not just standing on the leg, but it's actually that motion of moving a leg for the front, to the side, to the back, that will make it so that it is giving that flexibility and mobility within the ankle that's standing. So that's what I have for you guys for the foot and ankle common injuries, and looking at just what they are, and as well as what our corrective exercise continuums would look like in the process of trying to get people back into full activity again.